Welcome to the Technical Assistance Network for Children's Behavioral Health, Cultural Linguistic Competence Peer Learning Exchange. The Peer Learning Exchange is a monthly call or webinar whose topics focus on addressing health equity and disparities in children's behavioral health. Topics are generated by you, individuals, working in or being served by behavioral health organizations and partnering with system of care states and communities. The TA Network, as it is better known, is the National Training and Technical Assistance Center for Children's Behavioral Health for Substance Abuse and Mental Health Services Administration. It is the center, the Technical Training and Technical Assistance Center. My name is Kathy Lazier, and I'm a faculty member at the University of South Florida and the co-director of the Cultural Linguistic Competence Hub of the TA Network. For today's topic, Cultural Linguistic Competence Assessments, what's out there and what does it include, I am being joined by Selena Webster-Bass, Executive Director of the Voices Institute in Jacksonville, Florida. Selena's background is in public health, minority health, and health equity. Much of her work focuses on organizational development and leadership, and how attention to these areas is critical if we are to truly address behavioral health equity and eliminate disparities. In addition to a role as a national consultant with the TA Network, Selena is also the Cultural and Linguistic Competence Educator for the Jacksonville System of Care. This presentation is being recorded. Your lines are muted right now to help filter out any background noise, so use your chat box to type in any questions during the presentation. Following Selena's brief presentation, we'll open the lines for questions and discussion. So without further ado, I'll turn it over to Selena Webster-Bass.
Thank you, Kathy, for that introduction. And happy Thursday to everyone. So today our call will focus on cultural and linguistic competency curricula and professional learning or training for system of care communities. I've worked with the Jacksonville System of Care Initiative in Jacksonville, Florida for over 5 years and conducted trainings with a variety of audiences: foster care, case managers, nurses, clinicians, educators, organizational leaders, youth and families. And so our goals for this call are, one, to address the national culturally and linguistically appropriate standards, training, assessments, and evaluation, types of trainings, discuss core content for CLC trainings, and then to share some of the challenges and solutions in planning and conducting CLC training. I'm sorry, I'm getting a lot of feedback. I'm not sure.
Yes, I am as well.
Selena, what is your phone number?
I'm at 904-504-9772.
Okay. Okay, this should work now.
Okay.
Thank you.
Thank you. So what is cultural competency? Cultural competency is defined as the ability to communicate effectively across differences. And there are a variety of differences. Those differences may be a caregiver that has low health literacy and is challenged by the terminology that a behavioral health provider is using, or it could be a grandmother who's caring for a grandchild with ADHD and English is not her first language. And hence she may need interpretation and translation services. Or a difference could be a family who has a different belief system about mental illness, may not fully embrace the biomedical model of illness, and may need acknowledgement of their belief system. So cultural competency is about providing services in a respectful and compassionate way while considering the cultural needs of both the youth and the caregivers. We can also think about cultural competency from a macro level or organizational or systems level. CROSS defines cultural competency as those congruent behaviors, those attitudes and policies and structures that come together in an organization, a system, or agency that enables professionals to work effectively in cross-cultural considerations. We should also define linguistic competency, which is the ability to convey information in a simple and understandable way so that our youth and families may make informed health decisions. Cultural and linguistic competency practice is a strategy in eliminating health disparities, promoting health equity, and optimizing the health and well-being of diverse populations. The blueprint for cultural and linguistic competency practice is the National Culturally and Linguistically Appropriate Services Standards. These standards were originally published in 2000 and were republished in 2013. This framework is action-oriented and it provides recommendations for operationalizing cultural and linguistic competency and advancing health equity for children, youth, and families. Today, our webinar focuses on Standard 4, which is part of the CLAS themes of governance, leadership, and workforce development. Standard 4 says that organizations should educate and train governance, leadership, and workforce in culturally and linguistically appropriate policies and practices on an ongoing basis. And so it's really important that organizations invest in the support and training of their leaders, their supervisors, their direct service professionals, also parent partners and administrative professionals as well. It's so easy for individuals in behavioral health to become jaded because we're working with youth and families that are often in crisis. And oftentimes we find that professionals focus on the deficits of families rather than their strengths. And so it's important that we not use a one-size-fits-all approach, but we're individualized and that we use those cultural strengths as pathways to solutions. In addition, leaders should think creatively about policies and structures and processes that organizations can put into place to address the needs of diverse children, youth, and families. There is a long list of academic documents that confirm that disparities exist. There's the 2001 Institute of Medicine report, Crossing the Quality Chasm, which focuses on how our healthcare system should be safe, should provide quality services, timely, efficient, person-centered, and equitable care, which means that we provide care that does not vary in quality because of personal characteristics such as gender, ethnicity, race, sex, geographical location, and socioeconomic status. We also have our landmark unequal treatment report from the Institute of Medicine, which emphasizes that racial and ethnic minorities tend to receive lower quality of behavioral and primary care services than European or white Americans, even when insurance status, income, age, and severity of conditions are comparable. This report also confirms that more interpreters should be available in clinics and hospitals to overcome language barriers that may affect the quality of care. Systematic review of educational interventions across the health professions has found that cultural and linguistic competency has a positive influence on provider knowledge, skills, and attitudes, but we also know that more rigorous research is needed on various training formats, behavior change after trainings are conducted, and organizational changes as a result of training. So in my experience, one of the first steps in terms of providing training to system of care communities is conducting a training needs assessment. And this is a process of collecting information about an expressed or implied organizational need. And what I mean by expressed is, an employee or a case manager or a clinician may say that I need training in this particular area. Or it could be implied. Maybe there have been some challenges, communication challenges within the organization that may need to be addressed. In my experience, we formed a CLC or a Cultural Linguistic Competency Training Committee, And we really focused on what the gaps were between appropriate and non-appropriate cultural and linguistic competency behaviors. And we, in our committee, we came up with lots of topics. I would say the top of the list was the LGBTQ I2S population. Providers really wanted more information about how to address youth and caregivers in a more appropriate way, and also understanding the importance of providing reinforcing behaviors and supportive behaviors for our LGBTQ families. We also focused a lot on poverty, refugee immigrant populations. We had an influx of Bosnian and individuals that were from the Congo, and so providers wanted more information about views of mental illness specific to those groups. Youth culture was a popular topic as well, working with low literacy populations, working effectively with urban populations, and then also the topic of trauma in children of incarcerated parents. So those were just some of the topics that came out of our CLC committee in Jacksonville. As we conducted our needs assessment, we thought about cultural competency across 4 domains. The first one was cultural self-awareness. The second, multicultural populations. The third, cross-cultural communication and organizational cultural competency. And we also thought about which populations we wanted to train. And we came up with a list that included direct service professionals, leaders or key decision makers within organizations, and then youth and families. And our assessment focused on, of course, what topics we wanted to cover, how frequent we wanted to offer the trainings, the number of hours, how the training information would be reinforced once those individuals that participate in the training went back to their agencies. The training needs assessment was really helpful in terms of identifying priorities and developing a CLC training plan. So after we conducted our assessment, after we sent out a survey to several behavioral health providers, we charted a plan that included training goals, metrics in terms of pre and post knowledge surveys, the number of people we'd like to train, potential speakers, and also a calendar of training topics and the locations of those trainings. The training assessments that we used helped us to really prioritize topics and really helped us in determining what our training calendar would look like. And we also provide an opportunity for respondents to write in topics that may not have been listed on the training assessment. All right, so I'm going to take a moment to have a discussion question here. What cultural and linguistic competency professional learning formats have you used within your system of care community? What were some of the benefits of the various formats, and what were some of the challenges of the various formats used in your community? You may type your responses in the chat area. Okay, we haven't gotten any responses yet. Kathy or Linda, would you like to chime in on some of the formats that you've used in working with various audiences?
Yeah, I was just typing in one, and I was just going to say that some of the communities that we have worked with have called us and, asked for a short, online video presentation. And on one hand, we've heard that it's been really helpful to some of the states and communities to have these short online video kind of cultural competency learning formats. And on the other hand, we've heard from them that they feel that it doesn't quite get at, get at the intricacies and the subtleties, and there's not enough chance for discussion around it.
Okay. And that's a challenge, particularly with agencies that may not have a lot of time. You know, most of the time it's being spent, of course, with the families and coordinating services and providing clinical services. And so the short videos, yes, are very helpful, but may not get to the core of a lot of the cultural competency issues that may need to be addressed. So we have some responses here. Didactic formats have been used, so face-to-face, instructor-led formats, group facilitation formats, and the use of brief one-page fact sheets on specific disparities. Okay, great. Thank you for sharing. Any other comments? So I'd just like to touch on a few professional learner training formats that have been used. The face-to-face instructor-led training, of course, is probably the most popular technique. The benefit of this particular format is that everyone gets the same information at the same time. It can be more cost-effective, particularly if you're using in-house trainers. You can also leverage the experiences of the trainees that are in the room. And you have the ability to use a variety of training methodologies that may appeal to various learning styles, such as storytelling or role-playing, case studies, discussion, and so forth that may not be available if you use an e-learning format. The disadvantages of the face-to-face format is that the success of the training oftentimes is dependent on the facilitator. And so it's sometimes to replicate the experiences if you're just dependent on one facilitator versus standardized training. Scheduling can also be a challenge, which we experience in our community quite often. We found that 3 to 4 day trainings weren't, helpful in our community, in terms of getting participation. We oftentimes had attrition, and so 4 to 8 hour trainings seem to work better in terms of addressing cultural competency across the agencies. Another disadvantage of the face-to-face format is that sometimes when you have a large group, you're not able to be as interactive. So those are some of the advantages and disadvantages of the face-to-face or instructor-led trainings. Are there any comments from the group on that particular format? Okay. All right. So we'll move to the e-learning format, which is becoming more popular. You have your web-based training where organizations may place modules on an intranet so that their staff members can access cultural competency information. Also, video conferencing technology has become really popular as well. Audio conferencing, which involves audio only, not video conferencing. Webinars and web meetings. Multimedia, which includes animation, graphics, audio, video. It's a little more expensive, though, to use the multimedia format. And then virtual reality, which involves three-dimensional training experiences and simulations and so forth. The advantages of this format is that oftentimes it's effective for training across multiple locations. You can save lots of money on travel expenses. It's useful for refresher trainings and also good for self-directed learning as well. The disadvantage is that not everyone may be computer literate. Sometimes the information becomes generic and may not be as customized as compared to an instructor-led training. So that's another example of a learning format that may be used for cultural competency. Other formats include coaching. This is where an experienced provider working with multicultural populations may observe another provider interacting with families and then offers recommendations or feedback on ways to be more culturally sensitive to family needs. We often see this format in academic health settings. Providers may be video recorded, and the recording may be reviewed with an experienced provider, and then there's a conversation about the strengths and weaknesses of those interactions. So that's coaching format. Mentoring, an experienced provider working with multicultural populations may model appropriate rapport building skills, or an interpreter may train other interpreters, demonstrating the appropriate way to elicit cultural information. And then the final category is a service learning. And this is where individuals may spend time volunteering with a multicultural organization or ethnic-based community organization while also learning about cultural brokers, informal and formal community leaders, community resources, community perceptions of the healthcare system, or the behavioral health providers. So that's another format. And of course, we could use a blended format, which is what's recommended by the literature. The advantage of a blended format is that it really replicates how people learn and experience and interact with others. Any comments on the learning formats and some of your experiences in your communities in providing training and using these formats? Okay. Kathy, I see that you mentioned that you found success where there's training first and then followed up with a coaching model. Yep. Okay. Right. Any other comments?
This is Linda Selena. One of the things I was going to also echo what Kathy wrote in the chat area, that training first and then coaching. And another thing that I've seen work in cross-system collaboration, so looking at serving diverse populations, but also getting different organizations and systems to work together with different cultures and mandates, et cetera. And so, establishing like a committee or a table where folks meet and discuss some of these issues is kind of like with coaching, and then have leaders in the different systems or in research leaders, et cetera, to present on topics that are then discussed with like real world examples. It's almost like case conferencing in child welfare, but looking at a particular topic.
Great. Thank you for sharing that example. We have a comment from Ms. Burrell. She says that I agree that the blended model by trainers from more than one culture is very helpful too. Okay, thank you. Okay. And I just thought about an example of that. We offered a training on refugee immigrant populations in Jacksonville, specifically focused on mental health, and we had a panel of individuals that had recently migrated to the U.S., and they were from various regions. And it was wonderful to hear about their experiences and some of the challenges that they faced. Some of them had faced, war, conflict, and of course, some of them, had experiences with trauma. So again, to help our providers be more sensitive to the needs of populations, it's important that we also include youth and family and diverse, providers to share their unique perspectives. All right, so next we'd like to talk about the core content of cultural and linguistic competency training. And when you look at the literature, there's a lot of borrowing between primary care, the medical side, and behavioral health in terms of core content for cultural and linguistic competency. I'd like to break this section down in knowledge, attitudes, and skills from a competency perspective. And so if we think about knowledge and cultural competency, of course, we want to start with our definitions if you're offering a training, because everyone has a different view of cultural and linguistic competency. So with the system of care, we use CROSS's definition as well as some of the other definitions that are in the literature, but typically CROSS is our go-to definition, just to make sure that we're using standardized language and that we have a standardized understanding of cultural and linguistic competency, both from a micro and a macro perspective. Cultural responsiveness, culture, diversity, inclusion, and other related terms are important to define as well, because oftentimes people sort of, use these words interchangeably, and they're not all the same. So I find it very helpful early on to define terms and to make sure that everyone is on the same page. And of course, you can use various activities, games and quizzes and group work to emphasize these definitions. But it's really important to lay that basic foundation in terms of cultural competency knowledge. Also, in terms of frameworks, we use Terry Cross's Cultural Competency Continuum. There's also Bennett's model, which is very similar to Terry Cross's model. In terms of understanding youth culture, we used Roger Hart's ladder of youth participation. We've also used HIMSS continuum as well as a conceptual framework. And so these are just helpful in terms of helping people to understand that cultural competency is a developmental process, that it's a journey, not a destination, and that we are continuously in a process of self-assessment in terms of being culturally competent providers and even organizations as well. And then it's important to have data to support cultural and linguistic competency, epidemiological data in terms of health disparities, health equity, and then also tying that information to social determinants. Oftentimes we share data, but we don't talk about root causes and social determinants such as access to nutrition, access to safe communities, other factors that also play a critical role in the way that people seek healthcare services. It's also important to discuss cultural health beliefs of various cultural groups, but I also like to be careful in this area because sometimes we can end up stereotyping by saying, this particular group does this and this particular group does that. And so what we endorse is that you elicit information directly from the family and from the youth to understand what their cultural health beliefs are. So conducting a cultural assessment is important in terms of understanding the health beliefs and perceptions of individual family members, and also understanding risk factors and protective factors as well. In terms of organizational cultural competency, understanding the domains that can be operationalized in terms of meeting the cultural needs of families, organizational values, your human resources management, your communication services, your service delivery adaptations. All of these are important factors in terms of meeting the needs of diverse populations and reducing health disparities. In addressing attitudes, self-reflection is very important for providers, and again, it should be an ongoing process. And training should also be an ongoing process. It should not just be a one-time thing, but something that's happening on an ongoing basis and integrated throughout meetings and throughout policies. So self-reflection is important, understanding bias and stereotypes about various groups, and then exploring implicit and explicit bias is also important as well. There is the Project Implicit project with Harvard University that has questions that individuals can answer and determine their level of implicit and explicit bias. And so oftentimes I will ask participants to complete some of the surveys at Project Implicit website before coming to trainings and bringing their results to trainings, and use that as a discussion for stereotyping and for bias. Other topics related to cultural competency are what I call the isms, ethnocentrism, the belief that one group is superior to another group. So dealing with all of the different levels of racism, from environmental racism, modern racism, dealing with classism, sexism, heterosexism, adultism, which is how we treat children and our perceptions of children, and then, of course, ageism as well. So these are core areas specific to how people feel and believe about different cultural groups. The final group are the skills component of cultural linguistic competency, and this area is heavy in the communication side, communicating effectively across differences. So knowing how to conduct a cultural assessment and strengths discovery is really important for behavioral health providers, resolving conflict that may arise between professionals, but also conflicts that may arise between providers and youth and families that are being served. Health literacy, how we convey information so that it is simple, it's easy to understand. That's also a part of a skill because in developing materials, in developing forms for our families, the consent forms, the HIPAA, the compliance forms, making sure that they're written at a certain level so that our parents or caregivers are not intimidated or feel shameful because they may not understand the information. The use of interpreters and translation is also under this category as well in terms of individuals who may have a limited English proficiency. And then organizational self-assessments. How do organizational leaders, decision makers conduct assessments within their agencies to ensure that they are meeting the needs of diverse populations? Okay. Are there any comments or questions regarding the knowledge, attitudes, and skills section of CLC training? No? Okay. All right, so we'll go to our final slide, which is evaluation. I like to use Kilpatrick's 4 levels of evaluation. Kilpatrick says that we should measure the reaction of the learner to and their thoughts about the training experience, the learner's resulting knowledge gained from the training experience. The 3rd level is the behavioral change and improvement after applying the information, and then the results on the organizational outcomes or the health outcomes of the training So in my experiences, of course, we use pre and post survey with a lot of our trainings and professional learning. We've also done follow-up surveys at the 6 and 12-month period to see if there have been any organizational changes as a result of learning that's occurred, or how has their practice changed, And so I think it's really important that we're asking not just about knowledge, but how the information is being used in providers' day-to-day practice with children, youth, and families. So evaluation is really critical in terms of having metrics and also in terms of justifying the time spent in conducting training. So the metrics and the evaluations are really a critical component. In my experience with Jacksonville System of Care, we work very closely with University of Florida evaluation team, and so they assisted us in developing a lot of our pre and post surveys for our modules, as well as follow-up surveys and our training assessments as well. So they were very helpful with that.
So Selena, this is Linda. I was wondering if I could ask a quick question about evaluation.
Okay.
Or should I wait till the end?
We're at the end. We have a few discussion questions, but this is
okay.
a good time.
We can go ahead and unmute the lines now.
So I was just wondering if you might be able to share, I don't know if any findings are available, but what you found at 6 or the 12-month follow-up marks where post-training with regards to how providers are doing, and whether you have any way of assessing implementation that indicates that they're implementing what their changes in attitudes and learning.
Yes. So our follow-up surveys were conducted with organizational leaders. And all of our major leaders of our behavioral health organizations, executive directors, individuals that were in supervisory positions, individuals that were the key decision makers, participated in several of our cultural linguistic competency trainings. And so we really wanted to know, okay, how are you changing your practice within your organization to address the needs of children, youth, and families from diverse groups? And so one of the main things that was mentioned is that we're now doing training, because before System of Care, there was no community-wide training. And not only were they providing training to their organizations, but it became a part of their training policy. And I think that's a really important thing to emphasize, because it's not just, something that's going to happen on a whim, but it's something that, we're going to do this every 6 months, or we're going to do this annually, or, biannually. For different agencies, it was different schedules. The other thing was linguistic access plans, or language access plans. Several of the agencies that participated in our training actually went and looked at their policies in terms of how are we communicating to staff what to do if someone calls the agency, or if someone, connects with a family where English is not their first language. So language access plans was another thing that was mentioned. The other thing is, with our wraparound component, we introduced a standardized cultural assessment, and so many of the agencies have adopted that cultural assessment into their charts, and so it's required by their case managers to complete a cultural assessment with their families, and so that's required documentation, just like the CANS or a biopsychosocial assessment. It's required to be in the chart as well. So those are just a few examples of tangible, examples of things that organizational leaders have started at their agencies as a result of the trainings.
Great, thank you.
You're welcome. Okay. So we have a few discussion questions. The first question is to describe the CLC professional learning training process, some of the successes and challenges that you've had in your organization or community. And the second question is, what resources have been helpful in implementing cultural competency training in your organization or community?
Hi, this is Peter Gamache. Can you hear me?
Yes. Hi, Peter.
Hey, how are you?
Wonderful.
Thank you so much for this today. It's incredibly critical information for these communities, and I know that there are lots of communities that are struggling with being at the intersection of federal policies that are inclusive versus state and local policies that are not so inclusive, shall we say. Have you seen, with relation to policy development, have you seen that there's been a, increased need to address inclusive policies and guidance for how to best do that?
Yeah, I guess a part of our training has also been our organizational self-assessments with agencies, in the Jacksonville area. And, as part of that assessment, we reviewed non-discrimination policies. And many of the agencies had not updated their policies to include the LGBTQ population. So what I call SOGI, sexual orientation, gender identity, and expression, initially was not a part of non-discrimination statements. And so as a result of the training, because we've done lots of training around the LGBTQ group, we've seen some agencies, not all, but we've seen a few of our agencies actually include that now as part of their non-discrimination policy. So that's one example.
Yeah, and right now we're seeing, the sort of hot topic in the media is the transgender access to public facilities, and the messaging has really gone sideways and very negative, as if it's just going to open the floodgates to, all kinds of weird creep show scenarios and things that aren't really connected to reality. So, you know, and I understand where they're coming from. They're saying it's protective, or it's something to protect, I don't know, people, women, children, etc. And that's the argument, but then they're not considering those people who are really the most marginalized, which are people who are transgender. So the framing on this is really kind of, gone sideways, and a lot of mental health, behavioral health organizations are being looked to for leadership, or, what does this mean for services? I mean, I don't want to say exactly which states, but I'll say that, the several that I've been working with are, they're being asked, oh, are you still providing services, to this population, as if it's sort of okay to, to deny services now. So that's a major concern.
Yeah. Yeah, so these exclusionary policies and practices, also weigh on the mental health of these families and youth as well. And we know from the literature that it increases risk of, substance abuse, suicide, all of those things. So it's not just a political issue that's being toyed with, but it's also the health of our families and youth that we're serving. So it's an important issue. Thank you for bringing it up. Other comments?
This is Kathy. I was just curious about one of the things that we're working on is a kind of a rubric or a matrix to talk about what kinds of content, and you talked a lot about the different kinds of content that might be in a cultural linguistic competence curriculum. But I was just curious if anybody who's on the call has any ideas or thoughts about, what are the components that are the absolute, you cannot do a cultural competence training without talking about some things. I mean, I have been in some trainings where, sometimes they don't even mention LGBT, or they don't mention, in a sense, the word oppressed, oppression. And I was just curious if anybody else has come into or been to a training like that, or has pushback from their communities where they can't talk about some of those things, or are there things that can't be talked about when you're talking about cultural competence?
And Kathy, I can share that I was literally just on a call yesterday and with Chicago, an organization in Chicago, and they have very disparate groups that are, coming together, community coalitions that have a lot of disparities and, frustrations with systems, etc. And one of the common things that was said to get them all on the same page was to all talk about trauma, right? Because trauma is the common underlying, experience among these different populations. And so in terms of addressing the one thing, that especially for, cultural linguistic competence and getting coalition groups to come together, around common themes, that's what was raised, is that it was really about talking about trauma that got everybody to get on the same page. And I'm wondering if that's similar, if that's been a similar experience for others as well.
Sorry, you're hearing a lot of noise again.
Yes. Well, in my experience, yes, trauma comes up. Oftentimes we talk about historical trauma when we're addressing racism, as well as trauma associated with, refugee immigrant populations from war and conflict, and from the migration from their homeland to the U.S. And so, so it does help in terms of empathy building skills and making the connection with behavioral health as well. Are there other comments about successes and challenges? We'd love to hear from other communities. Any comments about resources that would be helpful in implementing cultural competency training in your community? Resources that maybe the TA can provide, or
as I said, this is Kathy again. As I talked about that, we are putting together and using a lot of the resources that have been out there in the past, through the National Cultural Competency Center at Georgetown, through the National Institute of Minority Health, and a number of other large institutions, and as well as the library that we have at USF, and are putting together, doing a huge search on all the different trainings and curricula that are out there right now. So hopefully we'll be getting that out to everyone this, the end of the summer in terms of this rubric about content for this types of training, as well as a guide also. So we'll be putting that out there by the end of the summer, and hopefully that will be helpful.
Thank you, Kathy. And I just put up the link to our USF Technical Assistant CLC resource site. So that's on slide 17, as well as a few other resources. Any final thoughts for the group? Okay. Kathy, Linda, anything you'd like to add?
No, thank you, Selena. And just to let you all know that we'll be sending out a link to everyone that registered for this particular webinar, and you'll have access to the recording and also to the PowerPoint. These calls, we really do listen to what you all have to say in terms of what kinds of things you'd like to have a discussion on. This was one of them. And so if you join us next month, we have this call the first Thursday of every month, so July 7th is the next call at 1 o'clock, the Peer Learning Exchange call. And the topic that has been brought to our attention that people would like to talk about is focused on the important role of informal supports and natural helpers. So you can look for the details in the TA telegram on that. But Selena, thank you very much again. And if anybody does have any questions or comments following this, please feel free to send us an email or the TA Network an email and ask us any questions or follow-up. But thank you all for joining us today on this particular call.